Hi, I'm Dr. Sandeep. We'll be dealing with hypertensive emergencies and urgencies in children. So as we know that hypertension is a hypertension can be fatal. It can also lead to a lot of morbidities and mortalities. It can also lead to adult hypertensions, and also can lead to end-stage kidney disease. So we should not deem pediatric hypertension to be a small thing. We should always treat them promptly. Before going into pediatric hypertensive emergencies and urgencies, we look at a little bit about the etiology first. So the most common causes in pediatric which can cause hypertension is because of the kidney involvement, or it could be because of endocrine abnormalities, or it could be neurological as well, and even cardiovascular. The most common cause mainly is because of could be because of renal and cardiovascular. In renal, in renal it is usually because of the renal parenchymal diseases, or it could be any glomerular disease as well. Apart from that, we also see hemolytic uremic syndromes and polycystic kidney disease, and rarely tumors. Coming to the endocrine, it is usually seen in pheochromocytomas, primary aldosteronism, and congenital adrenal hyperplasias. Neurologic wise, it is usually seen in raised intracranial pressures and cerebral hemorrhages or infarction. Even in cardiovascular, the most common reason for hypertension is because of the coarctations of aorta. Apart from that, usually in India it is not commonly seen, but in Western countries, because of drugs and other toxicological injections like cocaine and amphetamine, all these can also lead to hypertension. So, so before going into hypertensive emergencies and urgencies, as a pediatrician, we should know all the knowledge of pediatric BP standards, and we should also understand when we have to treat this hypertension, and when we should consider them to be an emergency or urgency, or just treat them on the OPD basis as a routine care. So whenever we are trying to deem a child to be hypertensive, we should always follow age established blood pressure charts, which are as per the height percentiles. So for Indian population, we already have the blood pressure charts by the Indian Academy of Pediatrics. So according to this, we look at the age of the child first, and then we look at the height centile. So depending on the height centile, if the child is falling in the 50th height percentile, then we take at the BP centile, which are corresponding to those height percentile. This is how we determine the blood pressures of that particular age and particular height for that particular sex. So we have blood pressure charts for both genders, that is male and boys and girls, and we also have.
Descending
Can you please mute your audios, please? So we'll have blood pressure charts according to the gender as well as the age and height. So according to the 2017 AAP guidelines, the pediatric blood pressure is categorized into normal blood pressure, elevated blood pressure, and hypertension. This is categorized for children between age 1 to 13 years and greater than 13 years, or adolescents. So normal blood pressure is the blood pressure when the systolic and the diastolic blood pressure is less than the 90th percentile for the age. This is for children between age 1 to 13 years. And elevated blood pressure is between 90th centile and 95th centile. We categorize a child to be hypertensive when the blood pressures are greater than 95th centile. So even in hypertension, we have two stages, that is stage 1 and stage 2. So stage 1 is the systolic and diastolic blood pressure, which is greater than 95th centile and is less than 90th plus 12 millimeter of mercury. Stage 2 is any blood pressures which are greater than the 90th centile plus 12 millimeter of mercury. And for children above 13 years of age, we consider them to be with the adult. We compare them to the adult standards, and the normal blood pressures are the blood pressures which are less than 120/80. And elevated blood pressure when the systolic is between 120 by 80 and the diastolic is still less than 80 millimeter of mercury. And the stage 1 and stage 1 is between 130 to 130 by 80 to 139 by 89, and stage 2 is greater than 140 by 90. So normal blood pressures that is less than 90th centile, elevated is between 90th and 95th, and stage 1 and hypertension is any blood pressure above 95th centile. So for stage 1 hypertension, that is the blood pressures when they are between 95th centile and 95 plus 12 millimeter of mercury. This is for these conditions, we usually take adequate amount of time to evaluate the cause for the stage 1 hypertension, and then we start with the non-pharmacological therapy. And then, if warranted, and if the patient is having any symptoms or any hypertensive target damage, target organ damage, then we opt for a pharmacological therapy. So these pharmacological therapies can range from ACE inhibitors, or it can be ARBs or calcium channel blockers. So we can choose accordingly. And coming to the stage 2 hypertension, where the blood pressures are greater than 95th centile plus 12 millimeter of mercury, or if the blood pressures are greater than 140 by 90 in case of adolescents, this we'll have to consider it to be urgent or it could be emergency. So urgency and emergency depending on the target organ damage. So what are the non-pharmacological managements that can be done in case of stage 1 hypertension? We can advise them for weight reduction. So it is postulated in adults that weight loss of almost 1 kilo can get down the systolic blood pressure by 1 millimeter of mercury. So weight reduction can significantly determine the decrease in blood pressures. Apart from that, even if the blood pressures are good, even if the weight reduction is achieved, they should be on regular exercise with restriction of sedentary activity. Along with that, we also have to advise dietary modifications with salt restriction. And other risk factors like smoking, alcohol, caffeine, and energy drinks should also be prohibited. So, how do you differentiate if a child is in hypertensive emergency or if it is a hypertensive urgency? So, as we've already seen that type 2, the stage 2 hypertension could be a hypertensive emergency or a hypertensive urgency. So this classification is usually arbitrary. That is how the differentiation between emergency and urgency is usually arbitrary, and the clinical judgment should be the gauge for the severity of hypertension. That means if there is any symptom of end organ damage, or if there are any symptoms which are causing some disturbances because of the hypertension, then you consider it to be a hypertensive emergency. Otherwise we consider it as urgency. So, for example, if we have a child who has a chronic hypertension and who has very high blood pressures, but most of the time they are asymptomatic. So these children, if they have a higher blood pressures, we consider them to be hypertensive urgency, but not an emergency because they don't have any symptoms. But a child who is absolutely normal before has an acute rise in blood pressures. These acute rise in blood pressures, with if there is any end organ damage, then we consider it to be an emergency, hypertensive emergency. So when we have a child who's come to you with urgency, we don't right away start with medication. Instead, we can evaluate properly and then we can start them on medications. But if there is any acute deterioration or change in the status, then we can start with the IV antihypertensive medications. And in case of hypertensive urgencies, like in the case of any chronic conditions, we should not aim to decrease the blood pressures suddenly, because their body has already got acclimatized to their high blood pressures. And if we suddenly reduce the blood pressures, they can lead to ischemia. This will come to again in the later slides. So whenever a child comes to you in hypertensive emergency, so as we've already seen in many other discussions before, the main our primary goal is always to maintain airway, breathing, and circulation. So this is done for all the patients. And apart from this, we also have to establish 2 IV lines whenever possible. So one IV line is always dedicated for the administration of antihypertensive medications. And whenever we put in the IV lines, we'll also have to take our initial investigational samples for the initial lab studies. And children with any hypertensive emergencies can always rapidly develop heart failure, can also have seizures and alter mental status. So in case if there are any seizures, we should promptly treat them with anticonvulsants until the seizure stop, and then we have to continue with anti-rage ICP measures like 3% NaCl and mannitol. And in patients with papilledema, altered mental status, seizures, or any neurological deficits, a proper physical examination should also be done and followed by a emergency neuroimaging. So regarding this, we'll again see in the next consecutive slides. So whenever a child comes to you with a hypertensive emergency, you should always confirm the elevated blood pressures first. So the blood pressures so we look at the blood pressures. If the blood pressures are greater than 90th percentile for children less than 13 years, or if it is greater than 130/80 for adolescents, if it is obtained by an oscillometric method, that is by the NIBPs, then we should always confirm by using the normal oscillatory method or by the manual method. And always care should be taken that proper cuff is used to measure the blood pressure. So according to the AAP guidelines, we should always measure the size of the cuff in such a way that first we look at the midpoint between the acromion and the olecranon. And in the midpoint, what we do is we take the arm circumference. So the bladder, which is in the cuff. So mind you, this is the cuff length can be different, but the bladder length is what is important. So the bladder's length should be at least 80% of the circumference of the arm, and the bladders should be at least 40% of the circumference of the arm circumference. So it should always be 40% of the width, 40% of the arm circumference per width, and 80% of the arm circumference and in breadth. In case if it is difficult, we can have these blood pressure cuff bladders recommended sizes at our bedside for easy use. Okay. Whenever a patient who presents to you with hypertension, we should always make sure that we take blood pressures in all the 4 limbs. That is in both upper extremity and lower extremity. This is because, as we've seen, one of the most common cause of raised blood pressures secondary to some cardiac involvement is coarctation of aorta. So in coarctation of aorta, we usually see that the right limb blood pressures are higher than the lower limb blood pressures. And even there could be a significant difference between the right and the right upper and the left upper blood pressures as well. So whenever we get a child who's having a high blood pressures, we should subsequent to the first initial measurements, we always should have a reliable method for obtaining the blood pressures. So it can be by an intraarterial line, or it can be secondary to an oscillometric device like your NIBP. But mind you that we should not waste our time obtaining a central line instead of starting the treatment for the hypertensive management. As soon as we have established that the child has an hypertensive emergency or urgency, we should also simultaneously look for any target organ damage. This is because our treatment varies depending on the type of organ involved and our physical examination as well. If the BP remains elevated on repeated measurements, you will also have to take a proper history, do a proper physical examination, and also look at the end organ damage as well. So what are the different end organ damages which we can see when a child comes to you with a hypertensive emergency? So the most common organs which are usually involved are the brain, heart, eyes, and the kidneys. So if you look at the central nervous system, they usually come with headache or altered mental status, and it can range from slight lethargy to coma or confusion as well. And they can also have seizures and irritability in case of any infants. When we do imaging, we can also see the on imaging, we can see there is a white matter edema. So this is usually considered to be PRES, or posterior reversible encephalopathy syndrome, or also known as reversible posterior leukoencephalopathy syndrome. This is usually a reversible condition, and as soon as we get control of the blood pressures, this is reversed. Apart from these headaches and altered mental stages, you can also see children with facial nerve palsy, with vision changes and hemiplegia. Coming to the eyes, fundus examination can give us a lot of details when it comes to hypertensive emergencies. We can see if there can be papilledema, there can be retinal hemorrhages or any exudates. So if you can see in this first image, usually there should be a clear differentiation near the optic disc. But as you can see, the differentiation is gone. And also there are some slight hemorrhages here, and also cotton wool spots are seen. So this is pathognomonic of hypertensive retinopathy. And if the hypertensive retinopathy, even at this condition, is not controlled, it can go to the next stage where there is whole obliteration of the optic disc. And also, apart from this, you can see all those punctate hemorrhages and all the wedge-shaped opacities, wedge-shaped hemorrhages seen on the retina. Coming to the heart, as we know that it can lead to heart failure. So you may see that there is the child can present with tachypnea, with pulmonary edema, and also they may develop S3 gallop. And also a newfound murmur can also be seen. So in this X-ray, as you can see, there are a lot of pulmonary edemas and cardiomegaly, indicating that there is a heart failure. Other target organ damage commonly seen is renal. The child can present with hematuria and proteinuria, which are usually the manifestations of glomerulonephritis, which is a common cause of hypertensive emergencies. Also, there is retention of fluid secondary to the renal disease. And this can also cause kidney injury. Okay, so there are some things which we have to understand before initiating a treatment. Usually in our body, for the blood to perfuse an organ, that is it depends on something which is known as the perfusion pressure. So the perfusion pressure depends on the inflow pressure, that is the mean arterial pressure, and the outflow pressure. Outflow pressure is the pressure that is exhibited by the organ or by the surroundings. In case of brain, the inflow pressure is our mean arterial pressure, and the outflow pressure is our intracranial pressure. So the perfusion pressure is the mean arterial pressure minus the intracranial pressure. The same is applied for the kidneys and other organs as well. So it depends. The perfusion pressure depends on the mean arterial pressure and the intra-abdominal pressure. So as you can see in this picture here, because of any raised intra-abdominal pressure, there is chinking of the vena cava. So the chinking of the vena cava will decrease the cardiac input, and thus it will decrease the cardiac output, and thus decreasing the mean arterial pressure. So in this way, the perfusion pressure is decreased. So when we see in a cerebral perfusion pressure, as we've seen, it depends on MAP and the ICP. So why are we looking at this MAP and ICP? So the main reason is whenever we want to start a blood pressure management, we also have to see if the condition with which the child has presented, does it warrant a rapid blood pressure lowering? So in conditions where, we are looking at conditions where rapid lowering of blood pressure is contraindicated. So in case if the child presents to you with a raised intracranial pressure, we have to differentiate if it is because of an intracranial hypertension or if it's because of a hypertensive encephalopathy. So in case if the child is having a head trauma or has a space occupying lesion or has a mass or has a stroke, in these conditions, there is raised intracranial hypertension. In these conditions, the body's response is to increase the blood pressure to maintain the mean arterial pressure, to maintain the cerebral perfusion pressure. But in case of hypertensive encephalopathy, the signs and symptoms are because of hypertension. So we have to differentiate between if it is an intracranial hypertension or if it is a hypertensive encephalopathy. Because in case of intracranial hypertension, we do not try to get down on the blood pressure. Instead, we'll try to reduce the intracranial hypertension. In case if we decrease the blood pressure suddenly in a child with high intracranial hypertension, it can lead to organ ischemia. So before we initiate the therapy, we should look at for all the signs of any stroke or any bleeding. So we should look at all the signs properly. So in this picture, you can see there is hemotympanum. So in these conditions, as you see that since there is high hemotympanum, we can establish the cause for the raised blood pressure to be an increased ICP. So in these conditions, rapid lowering of blood pressure is not warranted. Instead, we try to decrease the raised ICP. And also in cerebral herniation syndromes, even in all these conditions, we try to deal with the raised ICP instead of decreasing the mean arterial pressures. Apart from that, we also should see for the signs of any coarctation of aorta. So we should always look for the forelimb blood pressures, that is both the lower blood pressures and the lower limb blood pressures and upper limb blood pressures, to rule out coarctation of aorta. So things that is supposed to be kept in mind in our body, that is in the brain, it is always auto-regulated between the pressures of 50 millimeter of mercury to 150 millimeter of mercury. This is applicable in adults, but in case if the child is hypertensive, then the shift of this auto-regulation is towards the right. So the auto-regulation now shifts somewhere above 100 MAP and less than 200 MAP in this example. So if we get down the blood pressures to the normotensive side, then the organs can suffer a ischemic injury. So for hypertensive emergency, for chronic hypertensive patients, we should not get down blood pressures drastically. So even in these conditions, the hypertensive emergency should be dealt properly. Other conditions where it is imperative for us to treat the underlying cause is proper analgesia in case if the child is suffering with severe pain, then causing high blood pressures, and other injections like cocaine or amphetamine. In case of any pheochromocytomas and any envenomation, in all these conditions, we should be treating the underlying cause, after which the blood pressure will gradually decrease on their own. So if we have established a child to be having hypertensive emergency, so how do we deal with it? So our ultimate goal is not to achieve the BP value, is to achieve the BP systolic blood pressure that will promote resolution of life-threatening signs and symptoms and also prevent any end organ damage. So the normal accepted blood pressure goal is 95th centile, but 95th centile for children less than 13 years and less than 130/80 for adolescents. But the goal is it should be individualized to each patient depending on the response to the treatment. So many of the studies have found out that it is not just the value that is important. We should also look at the target damage, organ damage as well. So how do we decrease the blood pressure? So what we usually do is we usually get down the we usually determine the 95th percentile blood pressure for the child, and then we look at the current blood pressure, and then we subtract both of them. In case if the difference is around 40 millimeter of mercury, then we try to decrease 10 millimeter, that is 25% of it in the first 8 to 12 hours. Followed by next 25%, that is 10 millimeter of mercury in the next 8 to 12 hours. And then the final 50%, that is the remaining 20% over the next 24 hours. And in case if the child is hypersensitive to the blood pressure, and in case if the blood pressure falls suddenly, what we do is we give a bolus of 10 to 20 ml per kg. So this is so if there is overly rapid lowering of blood pressure, it can cause an irreversible target organ damage. So we always try to decrease the blood pressures gradually. So once again, we decrease the blood pressure by what we do is we calculate the difference between the current systolic blood pressure and the 95th percentile blood pressure of the patient, and then we decrease 25% of it in the first 8 to 12 hours, and next 25% in the next 8 to 12 hours, and the final 58th percentile, 58% of the blood pressure in next 24 hours. So we have so since it is a hypertensive emergencies, we usually prefer to give drugs as an IV infusion. The most commonly used drugs are labetalol and nicardipine. And apart from that, we can also use hydralazine and sodium nitroprusside. So the most commonly used drug is labetalol. It can be given as a bolus of 0.2 mg per kg to 1 mg per kg, and it can also be put as an infusion. So things to be noted here, it has a rapid onset of action and the duration of action is 2 to 6 hours. So it acts by alpha and beta adrenergic blocker. So since it is a alpha and beta adrenergic blocker, we cannot use it in a case of any asthma or bronchopulmonary or any BPDs. Mind you that this can also mask any symptoms of hypoglycemia. So glucose monitoring should also be done when the child is on a labetalol infusion. Apart from that, nicardipine can also be used, and hydralazine can also be used. And apart from that, we have two other drugs, which is esmolol and fendolapam. Sodium nitroprusside is also commonly used, but we should always keep in mind that it can lead to increased level of cyanide in the body. So if we are trying to use a nitroprusside for greater than 72 hours, we should always monitor the cyanide levels. And in case if there is cyanide levels are high, then we have to administer amyl nitrate or sodium thiosulfate. So for children with hypertensive emergencies, we usually suggest IV labetalol or nicardipine rather than hydralazine and sodium nitroprusside. Why? We'll come to that again. If it is an infant, we can give nicardipine, but also labetalol is also widely used. So as I told you before, labetalol can cause bronchoconstriction. So it has to be avoided in infants with chronic lung disease or children with any asthma, and it can also lead to pulmonary edema in children with heart failure. So labetalol can be given as initial bolus and then followed by infusion, and nicardipine can also be given as an infusion. But bolus doses are generally recommended in adults, but there are no pediatric studies where nicardipine was utilized as boluses. So why hydralazine and sodium nitroprusside are less preferred? So hydralazine has a slower onset of action, and the duration of action is very long. So in case if the blood pressure overshoots a lot to hypotensive side, then we won't be able to increase the blood pressure to the higher ranges. So it can lead to target organ ischemia. So it is usually not preferable. Otherwise, sodium nitroprusside is also less favored because of the cyanide toxicity. So in case if you are suspecting the child to have cyanide toxicity, what we can do is we can give sodium thiosulfate. So how much of sodium thiosulfate can we give? What we do is we give 1/10 of the dose of sodium nitroprusside, which was infused, and this 1/10 of the dose of sodium thiosulfate can help to mitigate the cyanide toxicity. Apart from these drugs, in case if the child also has a chronic disease or a volume overload, we may also have to give a diuretic therapy. Acute diuretic therapy can also be given in children with congestive heart failure and pulmonary edemas. Other drugs which are also seen are esmolol and fendolapam. And in case if diuretics are not helpful for correcting the fluid overload, then we may have to go for dialysis. So these are the drugs which can usually be given for treatment of hypertensive emergencies and hypertensive urgencies as well, in case of if there is any involvement of end organ damage. So how do we manage a child who has come to us with hypertensive urgency? So this is urgency. So if a child who has come to you with high blood pressures, what we do is we take repeated blood pressure readings. So since we are dealing with hypertensive emergencies, we can slightly take our time to evaluate whatever is going on. So we'll look for signs of any organ tissue damage. So if there is any organ tissue damage, then this will come to a category of hypertensive emergencies. If there is no organ tissue damage, then it will come into a condition of hypertensive urgency. So we evaluate for the cause of hypertensive urgency. So we look at all the conditions which you have seen before. And if there is any underlying cause, we treat the underlying cause. So treating that underlying cause can decrease the blood pressures. But in case of if the blood pressures are very high, we determine if it is a chronic elevation of blood pressure or acute elevation of blood pressure. So since chronic elevation of blood pressures, the body is already acclimatized to these high blood pressures, and since there are no symptoms, what we can do is we can give them oral medications. But if they are not able to take oral medications, or if there is acute elevation with some amount of some symptoms, then we can give a boluses of IV labetalol. So apart from this IV bolus, if you want, you can also give bolus of hydralazine or nicardipine. And also, if there are any signs of fluid overload, we give them diuretics. And then if the blood pressures are continuously monitored. And meanwhile, we can also start them on some oral antihypertensives to support our initial therapy. So coming to hypertensive emergencies. So hypertensive emergencies is hypertension with an end organ damage. So when a child comes to you with high blood pressures, we repeatedly measure the blood pressure, and then we determine if there are any life-threatening symptoms. So if there are no life-threatening symptoms, we go to the previous algorithm where there are and we treat as per the hypertensive urgency guidelines. And if there is hypertensive emergency, then what we do is we support the airway breathing, and as we have already seen, we obtain 2 IV lines, and we take relevant blood investigations, and we keep on measuring the blood pressures. And we also look at other end organ damages as well. So we look for all the papilledema, altered mental status, seizures, and other neurological physical examination. If there are any seizures, we treat them with benzodiazepine, and we obtain an emergency neuroimaging. So as we have seen before, this emergency neuroimaging is to determine the cause of raised, if there is any cause of raised ICT, which is secondary to a mass lesion or a intracranial hemorrhage. If it is because of a intracranial hypertension, we don't reduce the blood pressure. Instead, we treat the raised ICP, after which the blood pressure will automatically will be adjusted by the body. If it is because of, if the encephalopathy is because of high blood pressures, then we start treating them with IV and antihypertensives. So accordingly, we can start labetalol or nicardipine. And in case, as seen in the hypertensive urgencies as well, we also have to look for volume overload with signs of heart failure or pulmonary edema. And then in those cases, we can give antidiuretics. If there are no signs of any fluid overload, we keep on continuing with our IV antihypertensives. And then we keep on measuring our blood pressures. And in case if IV labetalol is not sufficient, we can also add hydralazine or nicardipine, and then we can gradually increase the dose. There is a habit by many people of using dipping capsules. Those are the short-acting oral nifedipine. But this is usually not recommended in children because there is no proper established dose for children. And also, apart from that, the action is also very unpredictable. It can also cause a risk of hypotension, and then as soon as the action is stopped, it can lead to rebound hypertension. So nifedipine, the short-acting nifedipine is usually not preferred in children with hypertensive emergencies. Even the other calcium channel blockers are too slow to act, so usually it is not recommended for hypertensive emergencies. In case if the child is not able to take oral medications, we can always give IV medications, IV boluses of labetalol or hydralazine or nicardipine. And after initiating the treatment, we should always look for complete history, do a complete physical examination, and should also do some ancillary studies to identify the etiology. Proper history should be taken, and all the symptoms from the patient should be elicited to know the possible cause of hypertension. So the parents may give you that the child has been suffering from headache, visual disturbances, or in case of any elevated intracranial pressures. Even in symptoms like in renal disease like Alport syndrome, we can see that there could be hearing loss. In case of catecholamine excess, there can be palpitations or irregular pulses. In other renal conditions like pyelonephritis, acute glomerulonephritis, they can give you a history of high colored urine or puffiness around the face. And in case of PSGN, they can also be recent medical history of pharyngitis or impetigo. Apart from that, there may be some medications which have been going which can cause hypertension. So the proper history should be taken for us to know the cause of possible cause of hypertension. Apart from that, what are the physical findings which we should see to so as to give for a clue? So we should always take we should always look at each organ system and then decide if it could be a cause for the hypertensive encephalopathy. In case of any hypertensive encephalopathy, there can be lethargy, coma, seizures, and other CNS conditions can also be should also be ruled out, like severe head trauma, child abuse. Although it is not common in India, in the Western countries, it is the incidence is almost as high as 40%. And apart from that, mass lesions can also be should also be taken into condition. They can also be features of hypertensive retinopathy. So fundus examination is a must. And apart from that, other signs of heart failure like dyspnea, orthopnea, edema, tachycardia, Gallop rhythm should be looked for. And in case of coarctation of aorta, all the four-limb blood pressure should be taken. For pheochromocytoma, there can be headache, diaphoresis, pallor, and tachycardia. Other renal parenchymal diseases or post-infectious glomerulonephritis, we should always look for hematuria, oliguria, anuria, or edema, and all. So, what are the investigations which are warranted? We should always get urea and creatinine to look for any renal failure, or to look for any renal disease which is causing the hypertension. We should also look for electrolytes, hypokalemia to see if there is any primary aldosteronism, Cushing syndrome or Reddy syndrome, hyperkalemia in case of any renal failure. Proper urine analysis should also be done to see if there is any proteinuria or hematuria. Complete blood count to see if there is any microangiopathic anemias with thrombocytopenia in case of hemolytic uremic syndrome. And X-rays should also be done to see the size of the heart and if there is any curly B lines for pulmonary edema. And also ECG and a 2D echo to see if there is any left ventricular hypertrophy. And neuroimaging is a must in case of any seizures or any focal deficits to see if there is any signs of raised ICP. And apart from that, we also should get a ultrasound abdomen to see how the kidney size is and how the shape of the kidneys and what is the echo texture. So what is the take-home message for today? We always should clinically differentiate between emergency and urgency. And then we have to take from there. Do not try to rush and decrease the blood pressure rapidly. As we have seen, the initial 25% of the difference of blood pressure should be tried to decrease. It should be tried to be decreased in the first 8 hours, and then 25% in the next 8 hours, and then the remaining 50% in the next 24 hours. Never use any short-acting nifedipine capsules to decrease blood pressure, as it can cause a rebound hypertension. And always try to maintain 2 IV lines, because administering other boluses or any drugs with antihypertensive medications can cause severe hypotension, and this severe hypotension can cause in-organ damage. Always try to determine the cause of hypertension before the initiation, because if we are trying to decrease the blood pressure in a case of raised ICT, it can cause ischemic damage. So we'll always have to differentiate between a raised ICT and hypertensive encephalopathy. And as soon as we start the initiation of treatment with parenteral therapy, we should always start an enteral antihypertensive drugs as well within 6 to 12 hours, so that it is easier for us to gradually wean off these antihypertensive medications, and then that is parenteral to enteral. Thank you. Any doubts? You can ask me.
You were regarding the types of antihypertension. There are few questions being put in the past on this topic. I would like to share them with you. First is, how do you differentiate cyanide toxicity in the patient who is on sodium nitroprusside for more than 48 hours? And second is, how and when should you start suspecting any kind of child who is unconscious in case of trauma, that could be because of hypertensive emergencies leading to stroke, rather?
Hello.
Yeah.